Okay. Good evening to everyone. Good morning, Dr. Rajaram Gopalakrishan. Many thanks to Dr. Rajaram for having accepted my invitation to conduct this webinar on behalf of the Department of Oral Pathology, SRM Dental College, Chennai. I extend a warm welcome to all the faculty members, postgraduate students and undergraduate students throughout the country who are keen in knowing the research prospects in dentistry. I'm sure that this webinar, Scope of Research in Dentistry, would widen your knowledge on research. I'd like to cite a Tamil proverb by the great poet Abbayar, Katrathu Kaiman Alavu, Kalladadu Ulagalavu, meaning what you have learned is a mere handful. What you haven't learned is the size of the world. Most of the nature's mysteries still lies unsolved or unknown. Most of the disease etiology remain idiopathic till date. Conducting intense research to sustain life is the need of the hour. In this context, I think this topic will be very appropriate, and I hope Dr. Rajaram's presentation will help the students to pursue more on the research aspect. Now I would call upon Dr. Nandini to introduce the guest speaker to the audience.
Good day to all. Dr. Raj Gopalakrishnan is a professor and director of the Division of Oral and Maxillofacial Pathology, School of Dentistry at the University of Minnesota. He is a diplomat of the American Board of Oral and Maxillofacial Pathology and a fellow of the American Academy of Oral and Maxillofacial Pathology. He has been at the University of Minnesota since 2002 and participates in an active surgical oral pathology practice in University Oral Pathology laboratories. He also has an active research lab investigating the molecular mechanism underlying early invasive phenotype in oral carcinogenesis. His other research includes the role of bone morphogenetic proteins and twisted gastrulation in bone remodeling and bisphosphonate related osteonecrosis of the jaws. Thank you.
Okay, can I start?
Yes, sir.
Oh, okay. Thank you very much to Dr. Rajkumar for inviting me. In the last 2 weeks, I've given 2 webinars, one to the Indian Association of Oral and Maxillofacial Pathology and one for this. Before this, I never spoke to you guys unless I came there. So this is a very good, I think the pandemic is doing its, it required a pandemic for us to all get together and talk about these things. So I will start sharing my screen and then I will go off screen so that you don't have to, listen to me. You can just follow what I'm saying. And you can follow anytime. How are we going to do with questions? Is somebody going to wait till, are we going to wait till the end or?
Sir, we're going to complete your entire presentation and okay. At the end we will answer the questions that are being asked, sir.
Okay, fantastic. So I don't have to keep following the chat, right?
No, not
okay. Sounds good. Sounds good. Okay. I'm going to share the screen. So let's see if you can see it. All of you can see my screen?
Yes, sir. Yes, sir.
Okay. Then I will stop my video. So.
So it's okay, sir. Your video can be on. Yeah. Your video can be on, sir. It's okay.
Okay. Let's see. Okay. Okay, so Dr. Rajkumar contacted me last month and asked me if I could talk about scope of research in dentistry. It's a pretty wide topic. I can give you a brief background of why this is important for me. Just like all of you, I was a dental student. I finished my BDS from Government Dental College in Chennai. It used to be University of Madras at that time. I graduated and I really wanted to do pathology as a specialty. So I was lucky enough I had the opportunity to come to the US and I came to do my specialty training, residency in oral and maxillofacial pathology at Ohio State University. And Dr. Ranganathan was there with me at the time, so we were together for almost the entire time. We went through our residency program together. And it was an eye-opening experience, to say the least, because I had never done research, not exposed to anything, I was always very curious about a lot of things, but pathology, I think, gave me, at least that program gave me, it is a 3-year program where you're allowed to get a master's at the end. So that was my first exposure to doing any kind of research, or I was encouraged to think for my own, to come up with a project on my own. And these were all very new to me. So I really enjoyed that part of, so it really was a big inspiration for me. And I stayed at Ohio State after that, and I pursued a PhD in pathobiology, which is in the medical school, because I realized at that time that I needed to, that research was going to be something part of my life, as well as of my career. So it really, and I hope that all of you consider research as something to pursue. It doesn't have to be bench basic research. It can be anything, just asking a question and trying to address it in your respective specialty. And for me, with pathology, it is limitless, the opportunities that I was given, and I took advantage of the opportunity. Some of them I was in the right place at the right time. I had a lot of people who were my mentors along the way, and all of you, I'm sure, have people you look up to. And I think it is okay for you to talk to them. It is okay for you to ask the questions. And if there is somebody in there who will encourage you to take one step further, I think you should take advantage of that and pursue that. So it is not a difficult, you don't have to be doing research at the highest level to find satisfaction in research. So you can, even a small amount of work, inquisitiveness, a curiosity, a question that is very simple that needs to be addressed, that you want to address, it can be addressed. Even that is, is what research is all about. So without, having that background of myself and where I come from, I just want to move on to, and I put this presentation together thinking in mind where all of the MDS, the postgraduate students, as well as the undergraduate students will be in about 5 to 10 years from now, okay? And that is what I was thinking what I should talk about. And then at the end of my talk, I'll talk about 2 research projects that I have from my lab. And right now I'm a professor here at the university. I'm tenured, and part of the tenure process here in the US is you have to do scholarly activity. You have to do research, and there was a lot of protected time that was given to me to do research. And I think pathology, and again, I'm going back to oral pathology because that is my area, is what I know very well, is very ideal, I think, for us to do research because of the background that you have. As well as I think it is tailored in to what we can achieve as an oral pathologist. Okay, so I'll start with that. This is I took this this line out of a very nice publication that came that was at both of these people, Dr. Polverini and Dr. Krebsbach. Dr. Polverini is actually an oral pathologist. He was the dean at University of Minnesota. He's the one who hired me to come here to University of Minnesota. And then he was the dean, retired as the dean. He's still a faculty member at University of Michigan, but he is a scientist and an oral pathologist. And Dr. Krebsbach was also at University of Michigan when I was there as a postdoctoral fellow, just doing research. And they wrote this, and he's now the dean at University of California in Los Angeles. So he wrote this nice paper. If any of you are interested, again, this is geared towards US dental schools, but I thought this statement was very telling. is only when a dental student comes to appreciate how research adds value to their education will they truly understand how research translates into better patient care. And there is a direct correlation between research. Again, there is this misconception that if you are going to be doing patient care, you are not a researcher. That is completely incorrect. In fact, it adds so much more value to how better you can take care of your patients if you understand the nuances or if you understand what you're talking about to your patient. And that is true for all the way from diagnosis, treatment planning, all the way until treatment, in any facet of your patient care. So I thought this was a very, very good line that is really something that I have used with my other students, with my own dental students here, as well as residents here at University of Minnesota. Okay, so why is research important? So research, innovation, and scholarship have always been core values. Everything you learn in your undergraduate and graduate, somebody has done some work on it. Okay, somebody has put some time and effort into asking that question that now has translated in your textbooks or in the publications that are out there, and that is what you're learning. So there is the scientific advances that inform dental practice is also paved the way for evidence-based decision making. Now that is a big thing, right? All of us want evidence-based dentistry. We want some kind of evidence in what we are doing to our patients or what we are in the dental practice. So participation in research directly impacts dental students' education experience. Now, I got that experience as a postgraduate when I was here at Ohio State. That is what motivated me to do a PhD and then do a postdoctoral research, where for 3 years I was at Michigan after my PhD was done, just doing research because I wanted to learn more. So I could be independent when I had a faculty position after that. Research also engages students' intellectual curiosity and provides an outlet for creativity. So it is things that you want to address. You can now, when I was a dental student at Madras Dental College, we did not have the internet, that we could go in and we could do a search online to figure out something. Now, all of you have tools to do that. And I would challenge everybody to take up one topic and do that and try to understand what that is. And I think a lot of this is incorporated in all of our dental curriculum in India. I've talked to so many of my classmates and friends that I know, as well as in the postgraduate level. We all do that in various levels. So that is, I think that is important. Research also is important for a student's understanding of the profession, and it makes you a better practitioner, okay? So you don't have to be doing research only in an educational setting. You can also, and then forget about it. You can also continue that when you're in your dental practice, okay? And at the end, at least for us in the US, and I'm sure it is the case in India too, where we are, dentistry is part of a bigger healthcare system. So it is by getting yourself involved in research, it puts you in position, I think, to be part of the medical profession. And there is one project I'll talk to you about today that is directly involved. For me, I had to talk to oncologists and endocrinologists on a regular basis about patient care. So it puts you in a very unique position to educate others, as well as be part of the evolving healthcare system. So as we go through as we get new technologies are discovered and are implemented, it facilitates that are important for diagnosis and treatment. Dental colleges and schools are expected now to provide the most up-to-date knowledge for predicting disease risk, for predicting disease onset, as well as to intervene them to halt the disease, right? So all of this are part of what you're learning in your dental colleges right now. So with that background, I want to talk about briefly, and this is available in NIDCR's website. NIDCR stands for National Institute of Dental and Craniofacial Research. This is part of the National Institute of Health. And this is available in their website freely. Anybody can go and look for this. Is they put up with a vision, with a strategic plan for how will dental, oral, and craniofacial research look in the next 15 years. This was initiated in 2015. So we are about 5 years into it now. So it's called NIDCR 2030. So I thought I will give you what they found, because that is where research will be going, I think, for you to understand. With that as a background, after that, I will talk about a couple of my projects that hopefully you will find interesting. Okay, so in 2030, NIDCR, their vision is to imagine a world where dental, oral, and craniofacial health and disease are understood in the context of the whole body, okay? So one of the first, they came up with 5 areas that they think are important. And with this globalization of health, the number 1 is oral health and overall health. So now when I was in dental college in the late 80s, things got to India, at least that's what we were told later, right? There was a time lag, but not anymore, right? Everything that is happening in the US or in the Americas or in anywhere in the world, in Japan, in China, everything comes to us very quickly, and we have to adapt to that very quickly. So that's what the first area is that the oral health will be part of the overall health. The second main focus was how we promote health, how we treat oral diseases, and there is a lot of focus on health disparities, that not everybody in this world are having access to dental care equally. So how can we make that better? Was also a big focus of what NIDCR is striving to do. So I think this is also what a lot of the things that in India you are trying to do, is to bring healthcare to everybody, dental care to everybody in the community. So they came up with 5 areas. So this was done by soliciting, anybody can go in there and they can give their opinion. And then there was an active vote taken, and the priorities were then I would say scaled, 1 through how much ever in different areas, as to how many people voted, which one particular topic got the highest vote. So these are the 5 areas NIDCR thinks that our research is going to go. Oral health and overall health, I mentioned that. Precision health, we'll talk about that, in which you design treatment to a specific patient. So we don't do a general treatment for all patients. We take each patient at a time and we treat them as an individual. We try to understand for example, if they have cancer, we are trying to understand what specific mutations they have, and we can specifically target that particular mutation. So that's what precision health means. Autotherapy, where you are using stem cells, for example, and trying to regenerate teeth. That's a very good example, and I'll show you a couple of examples of that. Oral biodevices is another big area of interest. Either it be implants, which is what has taken so much of the effort, is to try to have a better osseointegrating implant that would not fail. And then the last area, which varies from country to country, is workforce diversity, which for us here comes through interprofessional education. How well can we integrate with the rest of the health care, with pharmacists, with MD, with the medical school, with the vet school, with the nursing school. So that's the other part of workforce diversity. So again, and I will talk very briefly. I'm not going to spend a lot of time about this because I don't know much about, I'm not involved in that, but I can give a couple of things that we talked about that we are doing here in the US. So oral health, don't worry about what I wrote. It's basically trying to fit in where we are. The oral health is fully integrated into the overall health care for a deeper understanding. Okay, so we are not alone. We are not in a silo, separated from general health, what is happening in the endocrine system, but we are part of the general overall health. So one example, again, I'm only selecting one or two from each that NIDCR has focused on, and this is of interest where a lot of the periodontal research is going, is focused on oral mucosal immune barriers. So where we want to figure out the mechanisms that determine how oral mucosa functions as an immune barrier to control infection, okay? So we know from this slide, you can follow my cursor, our oral cavity is protected by the oral mucosa. We have different types of epithelium, which is the first barrier for anything that gets into our mouth, right? So there is a lot of focus, for example, based on the gingiva, right? Right in this area where we have a biofilm next to the tooth, you have a pocket that forms, then you have the gingiva, and then you have inflammation. So how well does this, and there is so much emphasis being put on how this particular area is important and how it plays a role not only in oral health, but in the general overall health of the patient. This is the nice review that I read, which talks about oral mucosa as an immune barrier. As for example, the microbes play, attack or affect the periodontal ligament space, the periodontium, and how the immune system changes to fight away the microorganisms. The exposure to various types of food now has become a big area within the periodontal research. Trauma or even allergens, all of this play a significant role in which the body is manipulated and their immune system is being manipulated. So this is an area that is ripe to be taken for any of us to do, to work on. And again, a lot of very nice work being done in India too on the on the periodontium and the overall health. If you look at the do a search, you will find so much fantastic work that is being done all over the world on this. The second area, and I'm only going to talk, there were like about 7 to 10 topics under each of these five big headings. But this is something that is of interest to me because of, so here in the US, oral pathologists see patients. We go down to the clinics. I know that certain dental schools, even in the US, it's a little bit different. But we have direct, we go down, we see patients, and we see the biopsies that comes from the patients. So it is a little bit of a different practice than maybe in some colleges in India or what I was used to when I was in dental college. But this is something that I have an interest in, and I'm working with this person right here, Cindy Stull. Cindy is a dental hygiene faculty here at University of Minnesota, and she published this really nice paper. So now, with regards to head and neck cancer, which I have a lot of interest in because of being an oral pathologist, we also have to deal with human papillomavirus and oropharyngeal cancers, right? So one of the things that Cindy is very interested in is in the US, currently we don't have any screening tools for oropharyngeal cancers. Okay, anyway, as far as I know. You only go to an ENT, an otolaryngologist, if you have a problem right in your throat. So the idea is that dentists see their patients once a year in the US for routine cleaning, or sometimes twice a year. So can dentists be in the healthcare system, can be the people who can actually screen, along with doing an oral exam, they will also do an oropharyngeal exam. And Cindy's interest is in education and in HPV vaccine. So she did a survey, she published this in Journal of Dental Hygiene, which was a really nice study, asking dentists and dental hygienists in Minnesota about what they know about HPV oropharyngeal cancer. It was just a survey, but it got so much important information. So I'm just showing you a type of research that any of us can do. This is not very difficult to do, okay? Do you routinely talk about oropharyngeal cancer with your patients? Do you perform an oral cancer screening on your patients? Just an oral exam, look at the sides, the lateral sides of the tongue, floor of the mouth, ventral tongue, soft palate. Do you look in the oral cavity? Do you look in the gingiva? We teach that to our dental students to do that on a routine basis. If yes, do you talk about HPV? And you can see that, you know, most of them, 75% of the dentists who answered the survey do not. So Cindy's whole interest is in trying to promote dentists talking about HPV vaccination. Now, I don't know the status of that in India, but here in the US, boys and girls are both now recommended to take the HPV vaccine. For girls, it was mostly for cervical cancer that was given a few years before, has been done for a long time. But for boys, it has been recommended about, I would say, 10, 12 years, or even less than that, I think. I don't know the exact time frame. And then she asked a series of questions about whether you talk about HPV vaccination. So this is a very simple research. So this is a big focus for NIDCR, is to have the dentists and the oral healthcare providers more engaged in HPV oropharyngeal cancer, okay? So a lot of them say, I don't remember to discuss about HPV vaccines, or I don't feel that they are qualified. So Cindy's whole area of interest, and I work with her, and we have a couple of proposals that we are writing, is to educate, maybe bring that into our dental school curriculum to engage the dental students as well as our postgraduate students to talk about HPV vaccination, and to also to communicate that with the patients. So anyway, that is a type, just one area of focus that I found to be right up my area of interest. With regards to precision health, which is you target treatment for a specific patient, depending on their genetics, depending on their behavioral as well as their social need. So one of the areas that NIDCR is going to focus on is in salivary gland cancers, is to target. NIDCR has invested a lot of money in the last 10, 15 years on preclinical models for salivary gland malignancies, so which is right up what I do in my practice. We see a lot of biopsies. Can we focus treatment on salivary gland tumors? So right now, for example, follow this chart that is in this publication that came out in Oral Oncology. Right now, the treatment is to give surgery, radiation, or chemo. Well, one of the things that is what precision medicine will do, or precision health is proposing to do, is that once you do a biopsy, use that to identify any particular genetic alterations, or you can do molecular pathology to do a PCR, or you can do FISH to identify a specific mutation or a gene that is altered in a particular patient, for that particular patient. And then you target your treatment along with surgery, radiation, and chemo. You target that particular patient, you put them on anti-EGFR antibody, for example, if that is what is needed, or you do an anti-HER2 antibody. And again, so you're focusing treatment on specific patients. So you're not, again, some of these cannot be practical in some situations, I understand that, but this is an area that I would like you to consider if that is of interest to you, especially for oral pathologists. This is a phenomenal area that is wide open, and we need to know so much about this, about these malignancies in particular. Now, it just is not for salivary gland tumors. Currently, there is a clinical trial at Stanford, I think. It was a very nice paper that came out in 2014 in Nature Genetics. If anybody wants to go back and check, this is in ameloblastomas. So here is a big radiolucent lesion in the mandible, as you can see in this patient. And the biopsy was confirmed as ameloblastoma. And I'm not going to give an oral pathology lecture here, but a lot of your oral pathology colleagues will recognize the pattern in this particular photomicrograph. But what this paper did was they looked for mutations and genetic or molecular characterizations of ameloblastomas, and they found that the maxillary ameloblastomas showed a specific mutation in the smoothen gene, and the mandibular ameloblastoma showed mutation in the BRAF gene, V600-E mutation that was found. So now, for some cases now, they are trying to target using medications that targets BRAF, and there are a couple of them that are in trial. This has also been used for melanomas in the for treatment. Now, can they be used for ameloblastomas? Okay, if that particular patient, and this is and you will see more about this in the coming years, especially after you are in practice. So all of this I'm showing you in one slide was done by years and years of research, where now it is directly helping these patients. So the idea is that you would then target that, you would shrink the tumor, and you will do less surgery, and you don't have to, you don't have to remove a significant amount of a patient's jaw, because currently that's what we do. We do marginal resection for ameloblastomas, right? So now we can also include this into the treatment protocol. The next area is autotherapy. Again, this is not in direct line. I have a lot of interest in tissue regeneration. As an oral pathologist, my role here is probably after the tissue, after surgery. I have a lot of interest. I work on stem cells, on a variety of stem cells, and one of the projects I'll talk to you about today is oral cancer stem cells, is to repair and regenerate teeth. Is one area that I have collaborated with a couple of people. But here is a nice review that you can study: is can we use the epithelium and the mesenchymal cells from a developing tooth bud, separate them out, and then put them in together as a bioengineered tooth germ to form a tooth, or at least a root. If you look in the literature, a lot of work has been done by endodontists in this area, by oral surgeons, by periodontists, especially when it comes to periodontal tissue regeneration, okay? Where you primarily use mesenchymal stem cells. You don't really need epithelium because you're trying to regenerate cementum or the periodontal ligament or bone. This paper, a good review, where I have shown you here in 2019, talks about the different sources of stem cells from dental tissues, either from the dental follicular cells, from teeth, deciduous teeth that are that have shed, from the dental pulp, or from the periodontal ligament space, or from even the apical pore, from the apex of a tooth. And you know, they have, you can use any of these cells and differentiate them into and use them for your regeneration strategies. And they go on to show how, what are the different players for both endogenous as well as exogenous stem cells, and how you can actually go on to make or to regenerate a tooth in vitro, which is in a cell dish outside the body, in a mouse model, and you know, I am very confident that it's just a matter of time that we bring it into the humans. So here is a nice paper that I'm not going to spend a lot of time here, that talks about exactly that, where they took a developing tooth from a pig, from mini pigs. They took the epithelium, they took the connective, the mesenchymal cells. This is the cap stage. So going back to your oral histology days. So we do study oral histology for a reason. We just don't study that because we have to pass and we have to go to the next stage of the next year of our dental college. Knowing your histology and your basic will help you a lot in understanding what happens to each of these things in the developing tooth. But you can take these epithelial cells, break them up into single cells, you can put them together, and in culture, they can actually form these little organized tooth buds. Or you can put them in the subrenal capsule, which is a very good environment, which has the environment, the microenvironment that is very similar to what we see in a developing tooth. And they were able to form a tooth. This is a histology of one such 3D culture that was implanted. And they were also able to show it in a mouse model, where they implanted them in a rodent model, sorry. Here is a mouse, yeah, in the upper jaw. They implanted these and let them grow, and they were able to form tooth-like structures. So this is a phenomenal, you know, in my opinion, achievement that maybe 30 years from now, we will be talking about this rather than making a prosthesis in a patient. The last two topics that was a focus for NIDCR is oral biodevices, okay? How can mouth be used as a real-time device? Or what changes, what devices can be placed in the mouth that will enable us to diagnose as well as to treat? I was gonna, the obvious thing that I can talk to you about is implants, but you know, it is so, I chose not to, because there is so much information out there. You can modify the external surface of the implants. You can put in bioactive peptides, antimicrobial. I have a colleague at University of Minnesota, Dr. Rajaram, who does a lot of phenomenal work on salivary antimicrobial peptide that they have isolated onto the implants and showed that there is a reduction in infection around the implant and better osseointegration. But what caught my attention as an oral pathologist is the development of these mucoadhesives. You know, this is a lot of chemistry here, and this came out of my my former mentor, who Susan Mallory, who was at Ohio State, who does a lot of really nice work, where she developed a gel using black raspberries. She works a lot on chemo prevention, especially dietary chemopreventive agents. And she has done this really nice study that was published in 2014, and she's followed that up with better mucoadhesives. Can we apply these to pre-malignant lesions in the mouth? And she has shown some evidence that you can actually reverse the lesions shown right here, right? You can actually reverse what is hyperkeratosis and some dysplasia into something that looks more less dysplastic, okay? Of course, we have a long way to go, but at least this is the type of work and she does a lot of collaborative work with chemists, with pharmacists, and she was I should admit that my biggest inspiration to become a researcher, because she's an oral pathologist, as well as, and that my first research project as an oral pathology postgraduate student, as a resident, I worked under Dr. Mallory, and that's what put my research interest peaked when I was in her lab. And I did a study on proliferative verrucous leukoplakia, which is a premalignant lesion, and a lot of your oral pathology colleagues will talk to you more about it. This is an area that I think we have to wait and see. That is a lot of interest to me, especially if we can help patients reverse their premalignant or even malignant phenotypes, oral cancer in the mouth. I always say that is one area that we can do these things because we can see it, other than the skin cancers, right? We can see stuff that is happening in the mouth, and we can try to work on trying to reverse that. The last area that NIDCR wants to focus on is workforce diversity, which again, varies from country to country, region to region. As you've been following the news, there is a lot of race-related issues in the US now. Everything happened that started it here, happened right here in Minneapolis, where I'm talking to you from, not very far from the university. And you can see how it has caught on. So there's a lot of workplace diversity issues, socioeconomic issues that NIDCR wants to focus. Again, those are different in different places. So India, it's a different issue. But one thing that is common that I felt that is very important for us that we are trying to do here, as well as what we should be trying to do in India, is to integrate dentistry with nursing and medicine and pharmacy. Okay, it is very important. We cannot remain as individual professions, as silos, and treat our patients. We have to integrate this, especially when some of you are moving towards an electronic record-keeping system, which I know is slowly coming to India. It is very important that we educate each other about each one of our profession, as well as work with each other to learn together, as well as to treat our patients. Okay, I'm not going to talk more about that. It's a pretty broad topic. So these are the 5 areas that I think at least NIDCR is going, and I'm sure these are in some way, may not be exactly the same, but in some way what we have to talk about. The other thing that I haven't talked about here that is a lot of importance is caries. Caries education, caries prevention, working up with a treatment plan for risk assessment, which again, to me, as an oral pathologist, I don't see a lot of that. So I'm not, I didn't really focus on that, but for a lot of you, that may be of great interest. And I think it is very important topic in India is caries and periodontal disease, which is the backbone of our profession of dentistry. So I want to move from there to, and this is a very busy slide, so don't worry about it. I just want to, I know this is being, in case, I know this is being recorded here, so you can always go back and look at this, but the broad categories of dental research is basic research, where we are asking a fundamental question about the structure, about knowledge about a particular cell or a function of a particular gene, and how the gene functions within a cell, or how do multiple genes and proteins interact. So these are very basic foundation level questions. Most of the time, these are starting point questions. Studies are typically performed at the cellular level. For example, you have identified a new gene, you screen for a particular type of cancer or a particular type of disease, and you identify a gene that is mutated, and now you want to figure out what is the function of the gene, right, within a cell. That is an example of basic research. Okay, clinical research takes what we studied in basic research and brings them to the chair. The clinical research is typically done on human subjects, and it explores whether new treatments, medications, or diagnostic techniques are safe, effective, and whether they can be, how effective they are in a patient. Now, linking the two is the translational research. Okay, so this is an essential link that connects the two. Because you can't directly go from a cellular level, from a lab, onto humans, because we don't know the efficacy of it. So a lot of testing is done. For example, if you identify a particular candidate, for example, when I talked about those BRAF mutations in ameloblastoma, when they identified the drugs that can target BRAF, first of all, they needed to know what BRAF did for them to even design a drug. So there was a lot of background basic research that went on. And before it got to the patient, to clinic, they tried it on in the lab as well as in animal models. So that's what translational research is that can we evaluate these? It's using intermediate models so you can get some idea of its toxicity, whether it's safe, what are the side effects before they move on to human clinical trials. So for dental research to be successful, and everything that you study in your dental college, in your curriculum, everything somebody has worked on it, and that is what we see in your textbooks. So there is a complex interplay for success of these, of chemistry, biology, biostatistics, genomics, pharmacology, as well as every other specialty to make this translation from basic to clinical successful, okay? And we can be a small part of any one of these. We don't have to do research we can answer a simple question. Just like in your area, in your city that you live in, is there a particular population that shows a higher level of caries risk? That can be a simple question that you can answer, and you will be able to address that. Or is there a particular population that you think has a higher risk for periodontal disease, and why is that? Could be one of the basic questions that we can start from when you observe, right? And then you try to understand that. You know, I didn't have to go very far to find how to go about it. There is, I mean, a lot of us probably are wondering, how do I jump into this, into start doing research? I want to do research, but maybe I just don't have the background for it. You can read, there is this paper came from India, and it is in Journal of Conservative Dentistry, which I found to be very simple about how do you identify research priorities. It's very simple. You probably have noticed it in your, as a dental student, as a postgraduate, there is something that you have asked a question and you have tried to do a search on, and you are not satisfied with what is out there. And you could use that as a starting point. So the main thing is we are trying to take an inventory of what is of existing research agendas. Meetings and conferences or workshops are really nice places to start getting ideas. Every time I go to either the International or American Association for Dental Research meeting, or the Oral Pathology meeting, IAOP, for example, I come back with so much energy and ideas that I want to pursue. But there is only so much you can do. So then you have to prioritize that. You have to bring it down. You have to set your research priorities. Then you start narrowing down your research questions to 1 or 2. Okay. If you have a list of 10, it is very difficult. It becomes totally out of focus. You want to focus yours to 1 or 2 main questions, just fundamental, simple questions that then you can talk to your colleagues and build up a team. Okay. Research is all about team. You cannot it is very hard to do it by yourself. You have to recruit people. You have different aspects that each member of the research team will bring for you. And that is why I feel that India is so good, because we have so many dental institutions, as well as so many undergraduate students and graduate and postgraduate students who are eager that we could form these different teams and will prioritize. Then you come up with a priority question, and then you figure out how to go about answering that particular question. Okay, so the main thing is to finalize a research question. You can also talk to your colleagues in other states, in other cities, as well as internationally, to see if this is a good question, if you know. And I get these questions periodically from people, and I will say, I know, I have discussed that, and I'll say, oh, that's a great idea, it's been done, or no, I think there's somebody else. I can come up with I think I read a paper somewhere, I'll send it to you, maybe that has already been done, but maybe the more focus should be on this. So talking to people is very important, and trying to get a collaborative, it's all about collaboration in research. So now you've finalized the research question, okay? After that, you have to come up with a hypothesis. It is important to come up with, and I'll talk about a couple of projects that I have done where I have I've tried, where we started with nothing and then we built an hypothesis. So hypothesis basically means you're posing a question, okay? Is a particular gene responsible for cell proliferation in cancer? Be a good enough question. I just made something up, right? But that is, again, a hypothesis, okay? You're saying that so-and-so gene accelerates or works on this particular stage of the cell cycle, and you're trying to answer that question. So you're going to pose a question, you're going to choose a sample size, you're going to choose a design for your experiment. Again, you're going to work with people. This is, there is a typo here, it should be ethical. You're ensuring, can the experiments be done, right? And do you have enough people or enough ability in your research team to analyze the data and how you will report it? So this is a very nice flow chart that I got from this very nice paper on how to design a research study. It is difficult when you start doing it first, because you're trying to focus. That is the main question, is to narrow down. But then once you do that, I think when you talk to the right people, there is enough research institutes in India that you can always contact them and have them help you to execute your research design. So these are, in my opinion, and again, these are all published papers. I'm not, but I agree with a lot of these things, and this is what I use for any successful research proposal, right? You need money to get your research done, unless you have money in some way from your own institution that will give you. But for us, we have to write grants to the National Institute of Health, to NIDCR, for example, or to the Department of Defense, or to the Science Foundation, I mean, NSF. There is just so much places that we can apply, but we have to write a good proposal that the reviewers who are reviewing my grant will find it interesting enough, that it is significant enough that they will give me money, which is not easy to do. So, but with training, with your working with others, and I know that there are people in India who have written some fantastic research proposals who can help you with that. These are the keys. Does your, is there a significance, okay? When you do, does the question that you're answering, is that significant enough, okay? Does it address an important problem? What is the impact of that question in your field, in the society in general, okay? Will it be helpful? Can I translate this 10 years, 15 years, 20 years into patient care? Your study design and methods, is that feasible? Now, you can propose doing GVAS studies in your, but do you have the ability to do that in your facility? Do you have enough people you have collaborated with who will be able to help you? Those are the things that a reviewer, a grant reviewer, is going to look for. Statistics is very important. Getting enough power in your sample size to get the results that you want. So the reviewers are going to look at that. So you have to address that. Innovation is important. This is, again, I'm showing you highlights of what NIH will look for in a research proposal. And I think this is standard for any granting agency. Is the project original is important, okay? You're not repeating something that has already been published, because then they're less likely to fund your project. Does the project lead to novel techniques and ideas that will advance your field, right? Are the investigators, the group, the research team that you have, are they experienced in the area? So you have to give, in your grant proposal, you have to write justification for what each person is going to be doing and what area they are experts in. And I think that is where the reviewers are going to look for and say, okay, this is a good grant. They have enough person to do GVAS studies. They're going to collaborate with that individual who has published in this particular area. So again, these are the kinds of things that I think they'll be looking for. And lastly, environment. Is your dental college supportive of your research? Are there enough facilities there? And you have to put everything in there, getting letters from your head of the department, getting letters from your principal, saying that we have enough patient, or if you're doing a clinical research, we will support this individual. We will give them the space to do their research. We will give them the protective time. For us in the US, that is very important. If I am writing a grant and I'm spending 20% of my time, salary is coming from the grant, then the institute, my dental school and my university should give me 20% of protected time to do the research. And these are the things that they are expecting in the letter from the institution, that we will give this, we will give Dr. Gopalakrishnan 20% protected time. So we will relieve him 1 day a week from doing duties within the dental school. So these are the kinds of things that are important for a successful research proposal. I'll be happy to discuss with people at another setting. It is a completely different thing about how to write a grant proposal, a successful grant proposal. It is, it takes some time and again, practice, but all of us have to start somewhere. And we didn't start writing grants when we were in high school or in dental college. So we started somewhere and we learn as we go through. So I'll be happy to do that. There are some really nice people also you can ask who have been very successful in writing grants that who will be able to talk to you about that, but I'll be happy to do that too. Okay, so that's about an hour was what I had thought that we will talk about the importance of research. I want to talk about, actually, when I put this together, I had just one example and then I changed it to 2 examples. So this is an error. I'll talk about a couple of projects that I have done in my career that are still ongoing, that hopefully in the next 30 minutes or so, I will finish and then we can open up for some questions, okay? The important thing for this is I want to show you cases. So this, as I mentioned, I'm an oral pathologist, and also as a researcher, I have my PhD was in cancer chemo prevention, in chemical carcinogenesis, to be more exact, in tobacco-related cancers. And then my postdoctoral research was on bone biology. I wanted to shift my focus from cancer because I wanted to learn about bone. you know, just to tell me as a side note, to tell everybody here who are, I have about 400 and odd people listening to this, or at least signed in. A lot of us forget that bone is an important part of dental health. You know, we look at tooth and then that is it. We don't look at the bone. And when I finished my PhD, I was really interested in bone biology. I wanted to see, and I realized that I didn't know much about bone. I had gone through dental school, I had gone through oral pathology residency, and I had gone through a PhD program in pathology and I really had very limited knowledge of how bone works. So my postdoc, I spent 3 years working in a basic bone biology lab doing osteoblast research and understanding how bone remodeling functioned. So keeping that in the background, we will go through this first research project, and I want to introduce to you a case. This is a patient who came to us with a 44-year-old. He had a history of renal cell cancer, and the patient had bone mets, okay, had lung as well as bone metastasis. And again, this may not be an issue that has come up in India that much, because I did talk to my friends, my classmates, about how many cases you see in India, but you will see, because at some point this may be used in the treatment in India. So I'll talk about Zometa in a second. But the patient presents with this. So the patient came to the dental clinic. This is from 2005. This is in oral surgery. They called me to come and see this patient. They extracted a tooth on this patient because, again, tooth number 30 and 31 are the American way of nomenclature, right? It is not what we use in India. This is the right mandibular first and second molar, okay? So this is in March, this is in May of 2000, and this is the, again, the date, the month come first. After the tooth was extracted, okay? And this is how the socket looked. This is in May, the socket has not healed very well. This is in June, this is in August, and this is in September. So what you're seeing here is the bone not healing. And if you take an explorer and you scrape that area, you will see necrotic bone, dead bone that comes out of that, okay? This is how the patient's panoramic radiograph looked in October. And this is how the CT looked. So you can see already that the CT is much better for this condition in showing how extensive the involvement is for this patient. So here is a second patient, patient with osteoporosis, right, 70-year-old, who is on a drug called Fosamax. Now I know this is given in India because I know patients who have had Fosamax, or otherwise called Alendronate, which is a bisphosphonate. And this patient presented to the dentist with this area. Again, she claimed that this necrotic bone, again, this is just exposed bone, is following a root canal treatment as well as a crown that was placed on this tooth. So these two are really good examples of a condition called medication-related osteonecrosis of the jaw. It's also called, the original name was osteonecrosis of the jaw, and then it changed to bisphosphonate-related osteonecrosis of the jaw because both of those patients I showed you were on bisphosphonates. Zometa is an intravenous bisphosphonate, and Fosamax and Boniva are both given for osteoporosis. They changed over the course of several years. The first patients were described in 2003, So right about the time I started as a faculty member here at University of Minnesota. Now we have added more to the list. There are more anti-resorptives. So bisphosphonates are considered anti-resorptives, which means they inhibit bone resorption. We have also included anti-angiogenic drugs. So drugs that will inhibit blood vessel formation, okay? So this is the American Association for Oral and Maxillofacial Surgery definition, 2014 update. Is the patient should be on current or previous treatment of bisphosphonates or anti-resorptives or anti-angiogenic agents. They have exposed bone in the jaws. Now, one thing that maybe many of you know this already, that this is only a condition that affects the jaw bones. It doesn't affect any other bone in the body, okay? And no history of radiation therapy or obvious metastatic disease. So a biopsy is done to make sure that there is no metastatic disease. And we also look at the clinical history to make sure, otherwise it becomes osteoradionecrosis. That's a complication. So 8 weeks is a time that is given because that's generally the time it takes for an extraction socket to heal. These are the medications that causes osteonecrosis of the jaw. We have IV bisphosphonates given to multiple myeloma patients, bone metastasis. A type is called reclast, which is an IV bisphosphonate. Zometa is given once a year for osteoporosis patient. That's a regimen. Oral bisphosphonates are given for osteoporosis as well as for other metabolic bone diseases. Rank ligand inhibitor. This is a very new anti-resorptive called denosumab. It also inhibits osteoclast. That's how bisphosphonates work. That's why I was talking to you about bone biology, how it is important for us to know the different types of cells in bone. We have an osteoblast, we have osteoclast, we have osteocytes. Each one of them have unique function and are important for bone remodeling. And then now we have a couple of more drugs that are included, which are anti-angiogenic drugs, which are given for gastrointestinal and renal and neuroendocrine malignancies. So a few more examples. Here is a patient. I'm not going to really talk much about clinical presentations and stuff, but here is one more patient with exposed bone. This was after extraction. Here is one in the mandible. The patient actually had a series of extractions done, and then the plan was to construct a denture. The patient was a cancer patient with on bisphosphonates, and this patient was at risk for developing osteonecrosis, and here is how they presented. Here is one that affected the entire. I have seen so many patients with osteonecrosis that here again it affected the entire maxilla from one quadrant as the patient had extractions done for construction of a full denture. Here is one that is not following an extraction, very similar to case 2 I showed you. Right in the mylohyoid ridge area, where the mucosa, the oral mucosa is very thin, way back in the lingual aspect. The mucosa on the mandibular tori are also pretty thin, and these are high-risk sites for osteonecrosis where the mucosa is very thin, okay? So they have a variety of clinical presentations, but there's nothing specific. Exposed bone in the mandible or maxilla, as I said, they have not been reported anywhere else. There was one report from Europe about a case in one of the middle ear bones, but I don't think it is really osteonecrosis. Patient will have very non-specific symptoms, pain, sore spots if they're wearing a denture. Diagnosis is typically made, clinical examination and patient history. The areas of exposed bone can be there for several days, weeks, or even years. I mean, we have followed some patients for a long time. They can be symptomatic once they get infected, and there is a staging system for that. AMS has come up with a staging system that will aid in treatment. What do you do for each? And still, we don't know what to do for these patients. Each oral surgeon and each oral healthcare provider and dentist does different things because we don't understand the biology of what happens in this condition. It's hard to treat. So it's very, you just treat for the symptoms. Sometimes we debride the dead bone and we clean it up and we put them on some antibiotics, put them on chlorhexidine to make sure they, for a period of time. And then some patients, they don't get better. For some of them, they get better and others will progress. So we are still in that situation. But this is a stage where we work a lot with the physicians, with the oncologists to tone down, and I'll talk to you about that in a second. So, as I said, I was interested in bone diseases. So, as an oral pathologist, this piqued my interest. We need to know what is going on in these patients. Why are they specifically affecting the jaw bones? All the cases reported were all either mandible or maxilla, mostly in the mandible, then in the maxilla. So I decided, again, I had a really good, at the same time, in our oral biology PhD program, we had a student who came to us from Bangalore, Vivek Tubagare Mutt, who took over this project and was really instrumental. He is now an assistant professor at University of Maryland. He's a periodontist now, and he's doing really well. So Vivek, one of the first things we did was, can we can we go back and check what is the status of, it used to be called bisphosphonate related at that time, in Minnesota. So we were focused on cancer patients. We didn't really focus on osteoporosis patient, just those patients with IV bisphosphonate. We went through our pharmacy database at University of Minnesota Cancer Hospital, as well as we worked with one other hospital in Minneapolis, in the Twin Cities, and we went through their database and we identified patients on bisphosphonates. And we wanted to find out what is, so we got, again, this was purely a retrospective chart review study. So for those of you, this is a type of clinical research we're interested where we just go back. We don't see any patients. We just go back and we review the charts. And only if the patient had reported to their oncologist that they have been diagnosed with osteonecrosis, we took their word for it. Out of the 576 patients, we had 18 patients who had ONJ. So that's about 3.1%, which is right around what was reported. Most of the patients were multiple myeloma patients, followed by breast and prostate, which is also the same what has been matched what was. So we published this in American Journal of Clinical Oncology in 2012. Most of it was in the posterior portion of the jaws, and again, 72% was in the mandible. So with regards to risk factors, we wanted to look for risk factors, by going through the chart. Can we pick up something and compare between those patients who developed osteonecrosis and those patients who did not? Okay, but they're all cancer patients who were on bisphosphonates. So what we found was that the mean number of infusions and the duration in which the patient took the was on bisphosphonate was important, was significantly higher. And those were the ones who developed osteonecrosis of the jaw. So that is why if you compare IV bisphosphonate to oral bisphosphonate, which is given for osteoporosis patient, you always see more IV bisphosphonate patients who developed osteonecrosis than, even though osteoporosis patient with oral, you had a risk, it was less. It was close to 1%, or even less than 1% with some studies, okay? And in our, and this took a long time. This took, Vivek spent, he had several dental students worked with us on this project. They would spend hours and hours of time going to the records place, and they will look at charts. And they'll go through every single thing that they found as being reported by the patient that was in the chart. We would then try to see if there was a significant difference between osteonecrosis, those patients who developed osteonecrosis and those patients who didn't. And these were the ones that came across as being very, very significant. Diabetes, which is now a well-known risk factor for osteonecrosis, just like with any other, with periodontal, with us, with oral health, it plays a significant role. Smoking, so those patients who were smoking versus non-smokers, the smokers were at a higher risk for osteonecrosis, as well as the number of zoledronate infusions, okay? The one thing that was novel, that was never reported before, was hypothyroidism. That we were able to pull out. And we still don't know the significance of that, because a lot of these patients were on replacement thyroid treatment. But we don't know at the time of osteonecrosis development what their thyroid hormone status was. Okay. So this was a summary, which was again in line. We wanted to get a baseline. So that was the first thing that we did. And again, this idea that hypothyroidism played a role, and we know that the thyroid hormone is significant, plays a significant role in bone remodeling. So that was something that was unique, and we did try to follow that up in other ways. But the second thing that we wanted to do was try to see what other risk factors that we could find that were local. This is such unique to the jawbones, right? That has been reported. I have not seen it in the femur. I have not seen it in the ribs. I have not seen it in any of the other bones. So what is so unique about the jawbones? So one of the things that was always proposed was, again, we knew that trauma was important, because about 60 to 65% of the cases were reported after a tooth extraction or some kind of dentoalveolar surgery. And then the remaining were spontaneous cases. So one of the things that was also reported was periodontal disease. So I worked with, again, Vivek, since he was interested in becoming a periodontist. His interest was just natural. We worked with a really good clinical researcher here at University of Minnesota, Dr. Michael Ovitz, and Dr. Kostalanga, who is in the faculty here, as well as our oral surgery faculty. Again, putting a team together is important. And our hypothesis was periodontal disease and periodontal pathogens are risk factors for ONJ development. And this was based on animal studies that were reported that periodontal disease increased ONJ risk, but there were no clinical studies that had validated. So our goal was to determine if we can associate clinical, radiographic, and microbiological measures and ONJ risk. So we selected patients. This was a case-controlled study. So a case-controlled study is where we select at one time, we bring in patients with ONJ and without ONJ, but all of them are on bisphosphonates, and we look at their periodontal status at that one time point, and we are comparing the two, okay? It is not a prospective study. It is not a study where we follow the patient over a course of 2, 3, 4, 5 years. And we wanted to look at their periodontal measurements. You don't have to worry about this. If you want, this is the review. We published this in Journal of Periodontology in 2014. You can review our patient population and where exactly the ONJ was in the 25 patients. So we had 25 ONJ patients and 48 controls, and we did the clinical periodontal measurements. So what we found was that in the adjusted, right, with bronze versus controls, the significant values were number of missing teeth. This was unadjusted and adjusted for age, sex, and smoking status. All the attachment loss was significant in both, as well as the percentage of the attachment loss was also significant. So all of the periodontal measurements were significant that we measured, but there was no difference. No, sorry, I take it back. Not all of them were significant. There was no difference in bleeding, in gingival index, or in plaque index. But again, one thing to remember is most patients were using chlorhexidine mouth rinse or were on antibiotics. So we really had to try to, it was very hard to match for those. So there might be some things that we missed because of that. But at least some of the periodontal measurements were significant. And then the bone loss, the alveolar bone height, was also significantly reduced in patients with ONJ compared to non-ONJ patients, okay? So we found, and we were able to publish and show that, that the poor periodontal status was noted in ONJ patients, and that the ONJ patients had more missing teeth, larger clinical attachment loss, and increased alveolar bone loss, and that the imbalances in antibiotics and chlorhexidine rinse between the groups probably eliminated some of the differences that we could have seen in some of the other periodontal measures. Again, you know, this was significant because now if these patients who are on bisphosphonates could just go see their dentist on a regular basis and get a cleaning done, maybe we can prevent osteonecrosis in these patients. It is entirely possible. So, in fact, that was done by a group out of Greece, as well as a couple of other groups, and they showed just that preventative measures there is less incidence of ONJ in those patients. This is the animal model that was published around the time we started. We were working where they developed an animal model for periodontal disease, as well as for osteonecrosis of the jaw, as well as a different group around the same time was able to show that any kind of inflammatory process, this was a periodontal disease that was created in these mice, as well as those treated with bisphosphonate, they were able to induce osteonecrotic lesions in those animals. So there is something to do with inflammation and with microbiology that was very unique to the jawbones that I think ONJ plays a role, okay? So again, lots of risk factors have been reported. I'm not going to spend a lot of time, but we were able to add to it into that category. The one other thing I want to talk about is the pathophysiology. So how does bisphosphonate work? Is by inhibiting osteoclasts, which are these large multinucleated cells. Their only function is to resorb bone, and that's what they do, okay, is to resorb bone. So here is how the bisphosphonates look. They have a very unique structure. They are so unique and so specific to bone, and that is why they are so effective anti-resorptors, because everything that is absorbed in the body goes to bone. But at the same time, they also have a long half-life. So they inhibit the bone resorption process. Again, you can review, you probably studied this in your first year about how bone remodeling works, where there is an old bone is being resorbed in the area, and then osteoclasts are recruited. Then they resorb the old bone, then osteoblasts are recruited to make up or to fill the space for. And this balance is lost in osteoporosis. And here is, they did a radiation uptake study with Alendronate, and it tells you that they injected it in rats. Here you can see the big osteoclast. But 4 hours after injection, you can see these little spots of bisphosphonate going to the bone, and then taken up by the osteoclast in 12 hours. Then in 7 weeks, you can still see bisphosphonates in the bone. And that is the problem with this condition, is that patients who have stopped taking the medication year, 2 years, 3 years are still at risk, because the half-life for bisphosphonates is almost 10 years. So they will stay in the bone for 10 years, so you're still at risk. So if somebody comes to an extraction to the clinic who has a history of bisphosphonate, they are still at risk. And we are not able to figure out how long it takes for the drugs to get lost from the body. So this is how they function in cancer as well as in osteoporosis. As you know, these cancer cells go to bone. They secrete a factor called rank ligand, which then activates the osteoclast, and that will resorb the osteoclast and will cause bone fracture, whereas bisphosphonates will prevent these osteoclasts. Once the osteoclasts chew on these bones, they take up the bisphosphonates and they die. And that's how bisphosphonates work, okay? What we showed was that why is it so unique to the jawbones, right? So the idea that the jawbones have a higher remodeling rate than any of the other bone in the body. it was very important for us to come up with a hypothesis that because of that, more bisphosphonates goes to the jawbones, and that if you do an extraction, that the remodeling rates are completely are reduced to such a degree that the bone is not able to remodel. Because when you extract a tooth, this is an extraction socket, remodeling is important for the socket to heal, okay? So this is 1 day all the way to 180 days after a tooth extraction. You can see the amount of bone remodeling that is taking place for the extraction socket to heal. So think about these patients who are on bisphosphonates, this socket is not healing. So in my opinion, osteonecrosis of a jaw is more of a healing problem with regards to remodeling. And that's why these patients are at a higher risk, okay? Again, there are other comorbidities that play a role, as well as other players like periodontal disease, etc. But it is, I think, important for us to recognize that. Here is a study that was done and published in Journal of Oral Maxillofacial Surgery, where they found bisphosphonate uptake in the jawbones to be pretty high following tooth extraction. Uptake of bisphosphonates, and we showed, this is our paper that came out, showed that in the socket, after we extract in rats, that the mineralization rate, which is a remodeling, a measure for remodeling, is significantly reduced in the extraction socket. So again, this is how I was able to work through a condition that nobody knows. And unfortunately, even to this date, after 16, 17 years after the condition was first described, we still don't know much about osteonecrosis of the jaw. I'm still interested. We still have a project that I collaborate with Dr. Tumbigere Matt, with Vivek, who's now in University of Maryland. Okay, I'm going to skip this. This just shows that at the extraction socket, we found a couple of markers to be pretty high. This is MMP9. And then we also did some salivary proteomics work where we showed that the matrix metalloproteinase is very high in osteonecrosis patients. So does matrix metalloproteinase play a role is what where I was going with that whole project, is what role does this play? Because MMPs are important for healing, for remodeling. Okay. And then I wanted to finish off this particular part by talking about the jawbones and why they have some unique stresses, and why, because of the complex microflora, because our jawbones are so unique, as well as the anatomy, with all the stresses, as well as the anatomy of the jawbones. I think all of this, it's multifactorial. All of these factors come to play a role in the pathogenesis of osteonecrosis of the jaw. There is one more project I wanted to talk about, but I can stop right here. We are at 1.5 hours since I started talking. I let up to the organizers to tell me if we should stop here and take some questions.
Sir, you can continue for another 10 minutes or so if you can.
Okay, do that. I'll be happy to. I'll do it quickly. I just wanted to talk about one other project that I'll just highlight important ones. So I have, as a pathologist, and I told you that pathology gives you the ability to investigate a variety of things, because that is part of what pathology is to understand oral diseases. I've always been interested in oral pre-malignant and malignant lesions, and we have done quite a bit of work over the years on that. One of the more recent projects, and here is some examples of oral cancer that I have seen. All of these are in high risk sites, lateral border of the tongue, lateral posterior aspect, as well as the floor of the mouth. So I've always been interested in oral cancer, where the etiology is multifactorial, with tobacco in a variety of ways, as well as alcohol. And now we also have started talking about human papillomavirus as a risk factor for head and neck cancer, which is more so for oropharyngeal cancer than for cancer of the tongue. So what has always interested me, I was very curious, is the idea that you have a dysplastic lesion and you remove it. You go all around the area, or you have an area of cancer. You remove it with clean margins. The patient goes through the full treatment, is cancer-free, but then at the same location, they get another tumor. It comes back. So my idea that both in pre-malignancy as well as in malignancy is there must be something else that is in the memory of these cells, all right, in the cancer cells, because cancer cells are very heterogeneous. So the idea that there is a cancer stem cell that is a small subset of cells that can self-renew, that can invade and metastasize, and is very difficult to get rid of, okay, could play a role. And this was the reason, this is how my interest started. And over the course of the last 10 years, we have put together a nice project looking at cancer stem cells. Now we have expanded them to HPV and HPV positive and negative, and also slowly trying to understand it in pre-malignant lesions. Is to ability to, I collaborated with a cancer biologist from the cancer center here who has been working on cancer stem cells. And we were able to isolate these cancer stem cell population from 3 different cell lines or head and neck cancer cell lines. The cancer cell lines have a unique their characteristic is that you can pick them up. There are some markers. So we use CD44 as well as we use ALDH. They have the ability to grow, proliferate, and have altered differentiation. They also have the ability to transition, to show epithelial mesenchymal transition, as well as invade and metastasize. And they are resistant to chemo and radiation therapy. So the idea that the cancer, that there is one cell in a group of cells, the survival of just this one cell is sufficient for it to move away. So the rest of the cells maybe will be susceptible to treatment, to chemo or radiation, but this one cell survives. It can undergo epithelial mesenchymal transition, can migrate, get into the bloodstream, and can seed itself and can start a new tumor population. Was very intriguing. So what we did was, there are several papers that have been published. There were conferences and workshops around this, is that if we can somehow target these stem cells, in addition to the traditional treatment of surgery, chemo, and radiation, then maybe that would provide a cure for a lot of our cancer patients. So that was the whole basis. So there are multiple targeting strategies that have been proposed, hypothesized. So one of the things that we wanted to do was target bone morphogenetic protein signaling, because there were several data out, papers that were, this is work done by one of the postdocs who works with me, who was able to pull out in cancer populations using the genome atlas that BMPs play a significant role. So the questions, so this complicated slide is just to tell you that we were interested in looking at how BMPs regulate bone morphogenetic proteins, or a group of growth factors that are important for bone. And I have done a lot of work. I published extensively on bone morphogenetic proteins and bone remodeling and osteoclast specifically. But we had a lot of tools in the lab that when we decided to look at BMPs, because of some data that was out there published by other labs, it was not a stretch to start working on that. So one of the first things, our hypothesis was that in the Bmp signaling pathway, BMPs bind to their receptors, they activate a transcription factor, they phosphorylate by phosphorylation SMAD158, that in collaboration with SMAD4 will move to the nucleus and will activate transcription of a variety of genes that are involved in cancer, in cell proliferation and differentiation. So our idea was, we knew that there was an inhibitor, there was endogenous inhibitor of BMP signaling called SMURF, which is SMAD-specific E3 ubiquitin protein ligase. It's a ligase. So we wanted to see the status of SMURF1 in the cancer stem cell population in head and neck. So we isolated these cells, okay? And we used CD44 as a marker to isolate these cells. So we pulled out those cells which were CD44 high. And then we looked for expression of SMAD and SMURF. And we can see that those cells, these are all the different cell lines, cancer stem cells showed higher level of SMURF1 expression, okay? As well as those same cells showed less SMAD, which is this one right here. So it's an inhibitor. So naturally, if SMURF was increased in the stem cells, phosphorylated SMAD will be down. And that's what we showed. So that was one of the first data we got. We also did that other than just in spears, which is what cancer stem cells can grow in culture. We also isolated them using FACS, and we showed the same thing, that the SMURF was increased and PSMAD was decreased. We then showed that actually the SMURF1 by flow, by cell sorting, that it actually mapped with the CD44X, because it could just be any cell that could be showing SMURF1, but we were able to show that it was the CD44 spear-derived cells, or the cancer stem cells that were expressing the SMURF. And all of this is published in Molecular Cancer. And with, then we decided to knock down SMURF1 using very nice short hairpin shRNA methodology. And we have used other things now from RNAi methodologies too, where we knock down SMURF and we showed that PSMAD comes back up, right? So that is it. So that is a reciprocity that is going on to show that SMURF1 is upregulated in cancer stem cells. And that could be a reason why if you block BMP signaling, then you're blocking the cancer, then actually that is helping the cancer stem cells. So we also knocked down the SMURF1 and we looked for what happens to the CD44 population. That shows that there was a reduced number of CD44 cells. Okay. So all of this helped us come to a hypothesis that SMURF1 plays a significant role, or is the key for maintaining the cancer stem cell population. Okay. And again, I just want to share with you one of the types of studies that you could do, other than one that was clinical, where I took a clinical problem and we were able to step by step figure out in our experience, what could be the risk factors, as well as did some basic studies. And then in this cancer stem cell population, in this oral cancer stem cell population, to figure out how BMP signaling and SMURF1, the focus of the studies right now has shifted towards downstream effects, as well as some other results that we got out of this. But this was the original study that was published on cancer stem cells, and we used to look and see if SMURF1 can be a potential target for inhibiting cancer stem cells. I want to stop here. I want to acknowledge all the people who are involved in the ONJ studies. Again, as I said, working with collaborators is very important, both at University of Minnesota as well as outside. And again, Dr. Vivek Math was instrumental in a lot of the studies. And then this is the Cancer Stem Cell Project, where I also worked with a variety. This is Dr. Erin Dickerson and Ali Kamaniwong, who were just instrumental for my collaboration for this project to be successful. And that is it. You know, I hope I satisfied what was asked of me, and maybe if not all, maybe some of you would be this would give an opportunity. This will make you think about research as a career, and also to you know, think and see that what specialties, you know, in any specialty you can do research, and how it will help you both in your career as well as in your practice. And again, oral pathology to me was the foundation for all the things that I was able to do, and the interest that I had and the curiosity to answer or to go after some of these questions. So I will stop here, and I can answer any questions or anything you might have. Thank you.
Thank you so much, sir. That was a mind-blowing lecture, and it has ignited our interest in research more than ever. Heartfelt thanks, Professor Dr. Raj Gopalakrishan, sir, for such an informative and thought-provoking lecture. Research has always been the key highlight of the Department of Oral Pathology because of the vision created by our HOD, sir, Dr. K. Rajkumar. Over to Dr. Dinesh to conduct the question and answer session.
Sir, there are a lot of questions from the session. Primarily consists of a few professors and a lot of postgraduate students and interns who are eager to pursue their career. So a lot of questions are based on that. So I will just read the question so that you will be able to answer. So this question is from Dr. Pratibha Ramani, Professor and Head, Savitha Dental College. She has posted, sir, your thoughts on artificial intelligence and precision medicine-based research in oral and maxillofacial pathology, as its translational research having impact on patient care.
Again, I talked about that as one of the areas that NIDCR is focusing on. Absolutely. I mean, artificial intelligence needs to catch up, but I know that a lot of them are working on trying to machine learning, as well as trying to have artificial intelligence with regards to diagnosis, at least. But definitely precision medicine. I already gave you a couple of examples in this talk. And I think that is where we are going, is patient-targeted treatment. Take one patient at a time and try to address, so that would help them better in their treatment. So we are able to prevent, and I agree with, I mean, I don't have anything else to say other than I think that that's where our field is moving towards, for sure.
Okay, thank you, sir. The next question is from Dr. Dinakar, Professor and Head, Sri Ramakrishna Dental College. Sir, he is asked, what's your opinion about including evidence-based dentistry, critically appraised topics, and problem-based learning in BDS curriculum?
Yes. If you have that, I mean, evidence, we are trying to do that. We have several courses on evidence-based dentistry here at University of Minnesota in the dental school curriculum. Problem-based learning is a little bit of a challenging. It is a mindset of the faculty, I think, more than the students. The faculty who are teaching has to change the way we teach, because it is not easy to come together and teach. You take a problem and you analyze every aspect of it, and you teach the students in that way. I know that University of Southern California has done that very successfully. They have included problem-based learning. In fact, a lot of the students don't even have to come to class. They have assignments. They have cases given to them in the beginning, and they do their own work, and they follow through benchmarks during the 4 years of their DDS training. We here at Minnesota are not a problem-based learning curriculum, but what we do is we do have a course directed by a couple of, including one who is our current dean now, but he was our associate dean for academic affairs, where we discuss cases. It's a case-based learning, where we present a case to the students. It's usually done in the 3rd year of their dental school. and a case is given to them, and they have to work every aspect of that with every specialty. So we have anatomy physiologists there, we have pathologists, we have periodontists if it is related to, for example, if the patient has diabetes and periodontal disease, then they include them into the picture. So there is a variety. So osteonecrosis of the jaw is a perfect case-based learning thing that we can use, because the students are exposed to anatomy, they are exposed to pharmacology, they are exposed to physiology, they are exposed to working with oral surgeons, they're with oncologists. So that opportunity is given. Again, evidence-based. A lot of our courses are evidence-based now. Absolutely. So yes, I am all for incorporating, but it is a mindset change by our faculty. It's a lot of work to move your curriculum from just coming and giving oral pathology lectures on a particular topic to working with other faculty to talk about a problem collectively. It's not that simple. But those schools who have done it, I know University of Michigan tried it. They had some ups and downs, but if you can do it and convince your faculty to do it, it'll be a real advantage for the students.
Thank you very much, sir, for that eye opener. As staff, we have to put our hands together to teach students problem-based learning. The next one is, sir, the question is from Dr. Praveena Raman, a postgraduate student. She's asked, please highlight artificial intelligence in dentistry. Is there any research pertaining to head and neck artificial intelligence?
Not that I should let you guys know that I don't know much about that. I have not, my background is I have not kept up with the artificial AI, but lot of the diagnosis for head and neck pathology, a lot of these machine learning, we have now reports of, for example, Aperio. I don't know if you have used Aperio system. It's a microscope imaging system where there are some evidence out there that you can teach these software. There are software programs where you can teach that to tell something that is with the morphology of individual cells as being teach the machine that certain parameters are something that can be malignant, something that is not malignant. And there is some people working on trying to teach these machines, and hopefully it won't come to that, then I won't have a job. But at least there is some data being tried where you can teach the machine to distinguish between something that is malignant. But I think where it will be most important is in those difficult cases, right? Where you're trying to decide between the specific type of malignancy, or even those important questions, right? Is this benign or malignant, because it's going to impact treatment. I'm not that knowledgeable about what all goes into that, but in other areas of dentistry, I know AI is a very strong, a lot of people are doing some really good research on that. I'm sorry I gave a very soft answer. I don't know the specifics of that. So.
Thank you, sir. Thank you very much, sir. Sir, this is a question from an oral pathologist. In the case that you discussed about the bronze case, apart from periodontal pathogens and systemic factors, were they tested for any genetic mutations associated, as they are all cancer-related patients?
That is a fantastic question. No, we did not. So there are some studies that are published looking for molecular alterations. They've done some polymorphism studies in ONJ patients. And there is some interesting data that have come out with some inflammatory markers. We did not do any genetic analysis. We did do salivary proteomics. I kind of skipped through the data in the end because we were collecting saliva from all of our patients. And we found a couple of groups of markers to be altered between osteonecrosis and patients and those patients who did not develop. But we did not, but there are papers out there with regards to, they have done some genetic analysis in ONJ patients.
Thank you, sir. And so from Dr. Karthika, reader from Karpagam Dental College, how do we validate a study or research to be original or novel? Is there any methodology for a study requires a key article?
So the question is, because there is something that is already published, how can you make sure it is novel? Is that what I'm assuming? I'm going to answer it that way.
Yeah, yeah.
Okay, so yes, so you're going to read a paper, but from that paper, I'm sure they have not addressed everything. There are some open-ended questions. Now, you can also do, even not just because a study has been published, it doesn't mean that you cannot answer the same question, because you might look for different genes looking for the same. So there are so many papers published in cell proliferation and oral cancer, right? But there are so many different genes that have been identified at different part during the spectrum of progression. So yes, we have to be a little bit careful for something to be, but you have to use studies that have been published as kind of things that you should be aware of, but at the same time so you don't pick those studies, but at the same time you can do those studies if you're trying to disprove what they have shown or trying to go in a different angle. If somebody has shown something in proliferation, you can show something in, well, they might also have a role in differentiation in some way. So for that, you have to know the basics of, yeah, it is always a struggle, but I think you will be able to find an area, and all of us do at some point if you have a research interest and focus.
Thank you, sir. So there is a question which says, in the upcoming years, by use, is there a role of oral biodevices? Can we identify caries or oral malignancies?
I hope so. I hope we have so many things that are in the works. I cannot talk for caries as much. I'm not knowledgeable about that area as much as oral cancers. But I mean, there are so many things that, I mean, even saliva as a monitoring device, can we pick up stuff in the saliva, are being developed by various labs in the US as well as around the world. Not only for oral malignancies, but I know Dr. Wang at UCLA has tried to use saliva as a device for monitoring breast cancer markers or, pancreatic. I mean, he's looking for a variety of alterations that he can pick up in the oral cavity. I am confident. I'm not sure in the upcoming year we'll be able to do it, but probably in a few years from now, that is where NIDCR wants to put some of their resources on.
Thank you, sir. Sir, amidst the questions, there is a wonderful feedback which was given by one pathologist who is from Dubai. She said, wonderful talk, sir. So she just wanted to highlight the role that oral pathologists can play in identifying all these lesions. So this is the entire feedback that she has sent. So I thought I should put it across to you so that you will know that how wonderful your presentation was. Thank you, sir.
Oh, thank you. And that is a perfect example of what we can do, is that we can work with other people. You should reach out to oncologists with the medical professionals, because they're always looking, and we can bring a very unique angle to their specific to their practice and their research. If we don't reach out to them, they will never know what we do. For example, I can tell you this, I've talked to this with some of my friends, oral pathology friends in India, too, is an area that is of interest to me now, and that purely came through because an oncologist, a bone marrow transplant physician contacted me to talk about oral cancer in Fanconi anemia patients. Okay, maybe not many of you know this, but oral cancer is Fanconi anemia patients are at a really, really high risk for oral cancer, more than any other solid organs in the body. And there is one line in the oral pathology textbook that we use for our students, which is the Neville Allen book and Chi book, Damn Allen, that's the book that I use for our students. And you can see there is one line as a risk. And I don't know in the books that you use whether we even talk about it. But he approached us and that's when I started having an interest in that. And I have talked to Dr. Ranganathan about it. I've talked to several people about it. But it is, when they ask you or when you reach out to them is when you get ideas. And it is very important and this is a very good example of that. I did not even think about it because most of those FA patients, Fanconi anemia patients don't come to us. They are diagnosed as a child in very young, and then they are managed by physicians all the time. They don't even, so we don't get to see them. But now here at University of Minnesota, I see all of the FA patients, whether they have oral lesions or not. I bring them in and we started a clinic just to see Fanconi anemia patients. And we have a lot of interesting research projects that have developed from that. So what is on screen right now is a very good example of one of those things, is we have to reach out to other people, and that will give us an opportunity to participate in some way for some condition. So
thank you, sir, for highlighting the.
Thank you for sharing. Yeah, that is really great.
Thank you, sir. So the next question is, do bronze and bronze occur in patients on bisphosphonates even after root canal treatment as mentioned? Sir, most of the students here most of the attendees here are postgraduate students and interns. So if you could explain what bronze and bronze is in a few words, and then it continue to be useful for them. Okay.
So that is the case. That is the first research area I talked about, which is bisphosphonate related osteonecrosis of the jaw or medication related osteonecrosis of the jaw. Well, this is a good point. Root canal treatment, typically we try to recommend root canal treatment for patients on bisphosphonates, especially those on IV bisphosphonate with oral cancer. But if you look at the endodontic literature, there is some report of ONJ in root canal treated patients, as well as there are animal models that I showed you in my talk where they have induced a periapical disease, and that has developed into osteonecrosis. But what I tell our patients, if they're on bisphosphonates, if they're on long-term bisphosphonates, is try to not extract the tooth if we can, and try to do root canal. So there are reports. I don't know if it is a cause and effect. I don't think that it does directly cause, because the amount of remodeling that is required for periapical for root canal, unless you have a periapical lesion, just by doing root canal, I don't think is, in fact, that's what we want them to do. We want them to be more conservative than more aggressive, like extracting a tooth. And, but sometimes the tooth has to go. You know, the patient, it's so abscessed or it has to be extracted. So what I tell you in that situation is talk to the patient, is educate the patient that this is a possibility, and try to get a consent form signed. Now here, these are important because there are legal implications for the providers. So we ask them to explain it, educate the patient, and get a consent form signed, so the patient is aware of the risks, that there is a small chance that I could develop osteonecrosis of the jaw when a tooth is being extracted. Or we even developed a consent form for any patients on bisphosphonates. It doesn't matter if they have to extract a tooth. Even for cleaning or for just visiting our clinic, we make sure that they sign a consent form. They know that there is a small risk. The risk is small, but it's still a risk for developing osteonecrosis of the jaw.
Thank you, sir. So there is a question from Professor Gadipoti Sridhar. Can illusions be a source of research problem or research question?
Absolutely, all the time. It is individuals' opinion. I mean, stuff that I come up with may not sound as a significant problem, or may not sound real for others. But that is why you have to do your background research before you start jumping into addressing something. You have to do our homework. We all have to do our homework in trying to see if it is real or if it is an illusion. But that is where a lot of projects will start. And we go down the wrong road because of that, and we come up with negative data. I have come up with more negative results, and that is okay. That is okay. Negative results is results. And then you change your track because the question you started asking was probably not the right one. So it is part of our careers if we go down this route. But you know, we have to do our due diligence in the beginning to make sure we reduce that, and we are absolutely sure that there is something there. And even then, even if I have a lot of evidence for it, sometimes I'm going down a path that I shouldn't be, and you have to realize that and be willing to change. You have to be flexible to change and go in a different direction halfway through your project.
Thank you, sir, for highlighting the importance of even the negative results in our research. So the next few set of questions are career oriented. So most of the students want to know how can they pursue their career after post graduation. So this is an MBA student from Government Dental College, Chennai. She is keen on pursuing a career in research after post graduation. So she wants to ask you, what is the path to doing research in the US? Do you have to do DDS prior to a PhD, or we can apply immediately after MDS?
So again, this is a question I get at least 1 or 2 emails a month from various students in India, and it's good that you asked me that question. So there are opportunities, and I will talk to you about how you come. I mean, there is no one way. When I came in '92, there were not very many people who were coming. But now I think there are several. I see every dental college here in the US has at least 1, 2, or more residents or postgraduates from India, or they're doing research in some way. You don't have to do your MDS to come to the US. Okay, that's first. I did not do it. The only negative in that is, if you go back to India without an MDS, you're going to have an issue, right? Because the Indian system is different. You go by MDS, and for example, if I come back to India, I don't know, Dr. Rajkumar, you can tell me, I don't think I will be qualified as an oral pathologist because I don't have an MDS from India. So those are the issues that you will face, right? But you will be a dentist, you will be a BDS. So if you look at those, the structure of how we, and the same thing is true. If you have an MDS from India, when you come to the US, that is not recognized, right? So you don't have to have a dental a master's degree from India to come. You can come and do research. There is no one way of doing it. You apply to, everything is online now. You can go to individual institutions, look and see if research is of interest to you. There are oral biology programs. They are called different ways. We call it oral biology. You can do, Michigan calls it diagnostic, and it's biological sciences or something. I know oral sciences is a term that is used, craniofacial sciences. So there's a variety of basic, but every school has a basic research department and a program where you can apply directly and get your, either do a master's or a PhD. Now residencies, specialty training, if you want to practice in the US, you will have to have a license, which means then you will have to either go to a state, and it is all state controlled, which will allow foreign nationals to take a licensing exam, which is almost very few states. Okay, I can't even, the rules change so much. But you can come and do a specialty training. You don't have to have a license. They'll give you a teaching license and you can do perio. But the problem is the competition, right? So the sought after programs like orthodontics and endodontics and oral surgery, you are competing with local domestic students. There are other specialty programs which are difficult to get in because there are not very many. For example, oral pathology, we only have 15 programs in the US and Canada together, maybe 16. And we take one student every year. University of Minnesota does not have a postgraduate. We don't have a postgraduate training program here for oral pathology. Perio takes international students. Again, it depends on where you stand and which program you apply to, okay? So for doing research though, you don't have to have, you can come and you can apply for an oral biology, a basic science program, and you can do research. That's how Vivek came to the US, and he did his PhD with me. He came as a master's student, then he changed to a PhD, did his PhD with me, then did his perio training here, went to NIH, did postdoc, and now is a faculty at Maryland. I mean, that's the career, that's the career I took, and path that I took. So, you know, yes, you can do it. You look at individual programs, what interests you. You can look at individual faculty members and see what research they do, and you can directly email them and say that I have an interest in that. If you, and you know, that is how you do it. So. I can't hear you.
Sorry, sir. My mic was on mute. Sorry. I think you've answered most of the questions, because most of the people have asked career-related questions. How to go about coming to the US for doing research. So this is another question. I think you've already answered the same set of questions. The possible career options for a fresher soon after finishing his post-graduation in oral pathology in India and foreign. So I'm just going to skip these questions because I think you've answered majority of these questions. This is how to start our research. I think you already touched upon this. Also, if you want to highlight some more things, if you can just touch upon a few things, sir.
I mean, how to start your research is, again, you have to have a question. So you should have done your background work on whatever question you want to answer. And you can always email people. If you can't find the right answer by access to journals or something, you can always talk to your colleagues, to your professors, to your mentors, or you can ask a person of interest. And people in general, most of them, will get back to you. They may not get back to you on the same day, but they will get back to you at some time. I don't think email has made it so easy now that people can address, and I don't see a reason why. I always try to answer as many people as...
I mean, for want of time, we are just cut-shorting those questions. There are still a lot more questions to answer. If you could share...
They can email me if they want.
Yeah, that's what I was about to tell you, sir. So if they can email you and ask you for the other options which are available. And thank you very much for your time, sir. And over to Dr. Ramya.
Thanks, Dr. Rajaram. Dr. Rajaram?
Yeah.
So thanks a lot. It was such an excellent presentation, because really the topic that was given to you, I had few things, because I had some reasons why this topic was given to you. Let me brief a little bit, because here the situation now in the dental colleges and as far as the oral pathology department is concerned, it's more of publications, funding, and patency. So it's gone the stage where, you know, the infrastructure facilities that you have in the college is no more considered as a criteria as far as your ratings of the college is concerned, whether it's a UGC, NAC, or we have a lot of ratings which decide which college is good. So the most important thing that comes into the aspect is the amount of funding that the department has generated or the staff has done. So now here we face the kind of a problem that you really touched upon. Now, people who are very excellent practitioners, excellent surgeons, or things like that, they feel that they don't have time to do research, or they feel that this is a different field that should be taken care of only by non-clinical specialty people. And you really touched upon saying how doing a research can help in your practice as well. So that's a very important thing. They can do that and still make use of it in their practice as well. So that was really nice. And the other thing you said, like exactly what are the factors that should be taken into consideration before you start a research proposal. And at our college, I am the secretary of the Institutional Ethical Committee and the Research Board. I face this kind of a problem, and some proposals come which are no novelty in their ideas. It becomes very difficult for me to reject it or send it back for kind of a modification, because there is no clear idea as to about some kind of a novelty of the project. So you touched upon that as well. And then the next question is, we think of in the terms, the moment the funding comes into our mind, we always think we are doing some studies, our studies or whatever that we have, is it good enough to send it for funding? And beautifully you explained how 2 cases that you got of osteonecrosis due to bisphosphonate, how you went back to a retrospective study about 500 patients, and how you found out that thyroidism and diabetes are playing an important role, and how you did a case control study to find out how periodontal factors play an impact. Absolutely, it is interesting how was 2 small cases, if you can create that kind of an interest in research and go back and do such a study, I think that people should think about it. And then we have a lot of scope now to think that the research is quite possible to take it to the next level, instead of thinking that we don't have that much of material to go for a funding. And about your second project, the cancer stem cells, whether it's an interesting one, I think for want of time, I think you can give a separate lecture to us and a separate time only on cancer stem cells, because it interests me a lot. Anyway, the idea with which the topic was given was very clearly fulfilled. I think everyone who listened to this must be having a very clear idea of how to pursue the research further and how to send the funding. So I'm extremely thankful for this wonderful presentation. It is absolutely amazing. Thanks a lot, Rajaram. And I now leave to the Dr. Ramya to conclude and say a few.
So in complete agreement with Professor Dr. Raj Gopalakrishan, we have experienced the best of oral pathology, especially during research proposal writing. As rightly mentioned by our HOD sir, the foundation of dentistry, I feel, lies in oral path, because every other specialty has a pathology core inside it. You name even a clinical specialty, and it helps us really into arriving at really good proposals every time. And that's why we have been very successful in getting the maximum number of research proposals. And there's a lot of research funding which we have already got. And this is to highlight to the young minds that research and innovation is key to make a mark in the society. When you create and innovate, you stand at par with the creator. You can contribute to the betterment of your mankind, and that makes you a complete human being. So create and innovate. And here are a few research highlights which we would like to share with the audience as well. The Department of Oral Pathology is excelling in research for the past 5 years, and we have received external research funding from the government to a core of 79 lakhs, and there are a lot of research proposals which are awaiting approval in tune of more than ₹1 crore. There are 2 wearable devices which are specifically designed by the Department of Oral Pathology for salivary stimulation and sublingual oximeter, and that has been patented in India and abroad as well. And we have validated a lot of salivary biomarkers for pre-malignant disorders, oral cancer, renal diseases, rheumatoid arthritis, and attention disorder, hyperactivity disorder. And Professor Dr. Rajaram, this is actually getting inspired from Dr. Wong. He was the one who had actually inspired us a decade back when we ventured into salivary biomarkers. And now after a decade, we have a lot of publications which have substantiated our role in saliva omics. We are right now working on organotyping of oral pre-malignant disorders. There was a government-funded student project on phytochemicals and stem cells in oral cancer, which was a government-funded project for a postgraduate. And there are a lot of international collaborative research projects. A few of them are related to oral cancer with Tokushima University, Japan, and Leeds University, United Kingdom. So here are a few things which oral pathology has to offer you at SRM Dental College. We serve as an eye-opener, and we always try to ignite young minds in research. We serve to guide other peers to write research proposals for government funding, and we also encourage to participate in ongoing research, external research activities with us. We conduct basic molecular research work for postgraduates from other institutions, and we also guide as how to patent your ideas. At this juncture, we again extend our warm thanks to Professor Dr. Gopalakrishan. This is a very small gesture from our end, sir, to you for having given a mind-blowing lecture to us and having ignited us to work more on research. Thank you so much, sir.
Thank you.
Yeah. And for the participants, please, after leaving the meeting, there will be a pop-up for participation in a feedback survey, which is very important for you to obtain your certificate. So please spend a few minutes to give a feedback, and that is very vital for you to get the certificate on time. Thank you so much, all the senior faculty and undergraduate and postgraduate students, for having participated in this mind-blowing lecture. Thank you one and all.
Thank you.
Thanks a lot, Rajaram. Thanks a lot.
Thank you.
Thank you very much. Thank you.
So thank you very much, sir. I think we have come to the end of the session. We will close the session now. Participants, you can leave as was instructed. Kindly fill up the forms for you to get the e-certificates. I think you can start leaving, and the session will end. Thank you very much, sir. Thank you, sir, for your wonderful presentation. Thank you, sir.